Hello, in this presentation, we're going to discuss syncope. I'm going to start off by showing a few YouTube videos.
Fainting is a brief loss of consciousness caused by a temporary reduction of blood flow to the brain.
There, just feeling a bit dizzy. All right, what we'll do is we'll just get you to the ground. I'm just going to get in behind you, just support you, just bend your knees.
Some people, if treated quickly, do not
Vi har brug for vaccinerne, og hvor valget... Ui!
Shocking video. An elderly man collapses in full cardiac arrest at an...
So now that you've seen those clinical presentations, we move on to the talk. ACC-AHA have defined this as transient complete loss of consciousness with inability to maintain posture, followed by rapid spontaneous recovery. The mechanism is transient global hypoperfusion. It is important to differentiate it from seizures, intoxication, and psychogenic events. The lifetime incidence is around 40%. Annual incidence is about 6 per 1,000 people years. Cardiac syncope has the highest mortality. If you look at this figure, it goes over different kinds of syncope. The black line is people with no syncope. The yellow line is vasovagal syncope. They're essentially one on top of the other. The red line is cardiac syncope and carries the highest mortality. Therefore, the key would be to figure out how to identify cardiac syncope. The cardiac causes of syncope include arrhythmic conditions, cardiac vascular non-arrhythmic conditions. The cardiac arrhythmic conditions include sustained or symptomatic ventricular tachycardia, symptomatic conduction system disease such as Morbid's type 2 or third degree heart block, sinus bradycardia or sinus pauses, symptomatic supraventricular tachycardia, pacemaker or ICD malfunction, inheritable cardiovascular conditions. The cardiac vascular conditions include severe aortic stenosis, cardiac tamponade, hypertrophic cardiomyopathy, prosthetic valve dysfunction, pulmonary embolism, aortic dissection, and moderate to severe LV dysfunction. Non-cardiac causes include severe anemia, GI bleed, etc. Now, there is a score called the EGSYS score. EGSYS score greater than 3 identifies cardiac syncope with a sensitivity of 95% in the study group, 92% in the follow-up group, specificity of 61% and 69% respectively. Score greater than 3 had a higher total mortality at 17% compared to 3%. In the validation cohort, the mortality was 21% in the patients with a score greater than 3 and 2% in those less than 3. The key features of the score include abnormal EKG and or structural heart disease with a score of 4, palpitations preceding syncope, syncope during effort, syncope while supine, precipitating and or predisposing factors, autonomic or neurovegetative prodromes. The major etiological categories: reflex would be vasovagal with prodrome triggers, orthostatic would be due to volume loss, would show a postural drop in blood pressure, cardiac would be exertional or supine syncope. Circumstances before the event should be noted. Witness account should be taken. Prodromal symptoms should be sought. Medication use should be looked at, and family history should be ascertained. Physical examination should include orthostasis. The definition of orthostasis would be a systolic blood pressure decrease on standing from lying greater than 20 millimeters in 1 or 3 minutes, a diastolic blood pressure decrease in standing or lying of greater than 10 millimeters in 1 or 3 minutes, or a systolic blood pressure drop to lower than 90 millimeters mercury. Typically, a 12-lead EKG should also be obtained to look for arrhythmias and to look for certain classic EKG findings such as the Brugada syndrome. There are certain known mimickers of syncope wherein patient passes out not due to volume not making it to the brain but due to other causes such as seizures, hypoglycemia, intoxication, brainstem stroke or TIA, cataplexy, and psychogenic causes, and these should be looked into. We'll go over a few example cases. 50-year-old Spanish-speaking man with hypertension, benign prostatic hypertrophy, syncopal episode at home. Medications include amlodipine, lisinopril. He's accidentally taking double the prescribed medication dosage. Terazosin. He has no trauma, no substance use. He's orthostatic on standing. This is a classic case of orthostatic hypotension. EKG is normal. Mechanism of orthostatic hypotension. There is inadequate autonomic compensation. There's a blood pressure drop after standing. Causes include volume depletion, medications such as alpha blockers, antidepressants, antipsychotics, neurogenic failure. Management strategy in such patients include review the medications and encourage salt and fluid intake, compression, stockings, and counter pressure maneuvers such as squatting, leg crossing, or hand grip. Pharmacological options include midodrine or fludrocortisone if needed. A second case is a 20-year-old female with no significant past medical history, presenting with a syncopal episode. A few hours ago, she passed out while trying to donate blood. She recalls seeing a needle, feeling nervous, dizzy, experiencing blurry vision. When she woke up, she was told by the nurse that she became pale, then lost consciousness for at the most 20 seconds. This has never happened to her before. She's been feeling well and does not take medications, does not smoke, drink, or use any other drugs. She has no family history of sudden cardiac death. This is typical for vasovagal syncope. The trigger is increased LV contraction, mechanoreceptor activation, drop in sympathetic tone, increased vagal tone, hypotension, and bradycardia. It has two different manifestations, vasodepressor and cardioinhibitory. In vasodepressor, there's a drop in blood pressure. In cardioinhibitory, there's bradycardia or asystole. Treatment includes reassurance, educate patient about common triggers, maintain hydration, counter pressure maneuvers. When you get a prodrome, you do a hand grip or a leg cross. Pharmacological therapy is rarely indicated. A third case is a 75-year-old gentleman with chronic kidney disease, peripheral vascular disease, moderate aortic stenosis, hypertension, type 2 diabetes, presenting with syncope, who was brought in by hospital staff, found him slumped over outside the hospital on a bench. Witnesses say he passed out for a couple of minutes. He doesn't remember any prodrome. Medications are nifedipine, losartan, insulin, Jardiance, and aspirin. He has had no recent hypoglycemic episodes. Physical exam shows an ejection systolic murmur with a diamond shape. That case would be aortic stenosis. Now, in this case number 4 is a 30-year-old gentleman with no significant past medical history presenting to the ER for syncope, brought in by his friend who witnessed the episode. They were playing basketball when he collapsed to the floor. He regained consciousness after 1 to 2 minutes. There were no convulsions, tongue biting, or urinary incontinence. Does not remember prodromal symptoms. And besides infrequent pickup basketball games, does not exercise regularly. His EKG shows the classic ST elevation in V1, V2, typical for Brugada syndrome. So if you recall our videos, the video of the first video I showed you with the person gradually sinking to the floor would be vasovagal. The second video where the patient passed out while presenting could also represent vasovagal. The third video with the gentleman who was young with syncope happening with exercise would be malignant cardiac syncope. And the fourth one with the elderly gentleman collapsing at the ATM would be cardiac syncope. Thank you for watching. More to follow.